Yeah, tell me, what are all the questions? Can you read out? Prashant, Prashant, can you hear me? Am I audible?
Yes, sir. Yes, sir.
Yeah, can you just read out the question so that I can answer, or if I can find it in my chat box, okay?
Yes.
Yeah, chat box, okay. Let me open that 1 second, please. So, Dr. RS. Persons with erratic dietary patterns may benefit from adagasp, which is seen very often due to professional commitment and culture, like Ramadan, etc. Yes, absolutely. I told you the co-formulation, the only co-formulation available in the world is only insulin degludec and aspart. So that is called basal plus. That is definitely superior when compared to, you cannot put it under the basket of this the premix insulins. That's a totally different one. Rhizodec is from Novo Nordisk. That is the combination of insulin degludec and aspart. It is absolutely a co-formulation, and it's called basal plus insulin. It is not a biphasic premixed insulin. But we start this with the largest meal of the meals. The you need to ask the patient which is the largest meal, either the breakfast or the lunch or the dinner. We start with the 10 units of this rhizodec. Okay, absolutely, this is superior to all the existing molecules as far as insulins are concerned in the world. Okay, absolutely, yes. So, Dr. DL, it's a great session, sir. Thank you so much. And Dr. Ranjita is typing. So, any questions you find actually?
Yes, Krishna, can I come in?
Hi, Rajdeep, most welcome to my session. I've seen you, Rajdeep. Rajdeep, I've seen you. Yeah, please, please. Yeah. Yeah, I was just waiting for your questions. Okay. Somehow you were able to take out some time during the very busy and very precious schedule of yours. Thank you so much. Dr. Rajdeep Srivastav is my classmate, my very close friend from the last 42 years. Ever since we joined medicine, we studied together. Okay, yeah.
Yes, thank you, but this topic is more important than anything else, Krishna.
Yeah, thank you so much, Rajdeep. Especially we took it because the Indian context is totally different. The Indian scenario is
Yes.
totally different as far as the socio-cultural, economic variations and the dietary variations are concerned when compared to the rest of the world.
Yes, I got your point.
Yeah,
I mean, this is question related to OHA, right?
yeah,
Uh,
not an issue.
Like, yeah, this is like, I've seen just there's a clinical inertia, there's an inertia from the patient perspective also. There is some misconception about the insulin, insulin also. So, so my question very specific is,
Yeah,
how about initially on the metformin, linagliptin twice a day, and starting with the glyphosate XR60 before breakfast, and taking for the 2 months, 3 months, then repeat the test, all this gastric tract, and then we shift on to the your premix, whatever insulin we want to initiate. This is the question which is haunting me.
yeah, it's a wonderful question, Rajdeep. Actually, what you mean to say is, instead of directly going for this particular the case of newly detected type 2 diabetes, or the patient has come to you from some other doctor, patient has seen you, and you want to put the patient on metformin twice, and linagliptin is always once a day. You can if it is used with metformin, the company people have divided it into 2 doses. But linagliptin is a true 24-hour acting DPP4 inhibitor. You can use it once a day. Along metformin, as usual, that is wonderful. And you are using a glycoside 30 milligram XR. So that is that is an excellent approach actually. So thereby you are using one insulin sensitizer as per the recommendations. You are sticking to the recommendations. You are using metformin twice a day, and you have as I said, the verified trial. Verified trial we did with only this vildagliptin. It doesn't mean that you should confine yourself to vildagliptin only. You can go for either sitagliptin, or the best gliptin is linagliptin. So you can select linagliptin. You have added DPP4 inhibitor with an insulin sensitizer, the best sensitizer and the first drug of choice, the metformin, unless otherwise contraindicated or not tolerated by the patient. And on top of it, you have taken this particular the glycoside, definitely the modern sulfonylureas in the form of extended release. So that's a very good option. You can try 3 drugs at a time, and after after a couple of weeks, after 4 weeks, you can again check this. You should have the baseline, the glycemic triad with you, the fasting plasma glucose and the 2-hour plasma glucose and the HbA1c, and you don't need to repeat HbA1c before 3 months. So you can go for a checkup, the SMBG or the lab test, and if you find that the patient is doing extraordinarily well with your triple drug combination, you don't need to use the premix insulin at all.
Okay.
That's a wonderful. Usually we cannot rule out using this particular the sulfonylureas in our Indian scenario, especially either the glycoside, I said modified release or extended release, whatever it may be, or the glimepiride. So these two can be used actually. And the latest research has rolled out saying that these two sulfonylureas have got the better cardiovascular safety, and the mortality and morbidity is much reduced when you use this, and the glimepiride stands tall amongst all the sulfonylureas. With regards to the ischemic preconditioning, that is called IPC, which favors in lessening the incidence of the cardiovascular incidents, actually the heart attacks and the strokes. So in that case also, your version is terribly good, that okay, you have taken one sensitizer, you have taken one DPP4 inhibitor, and you have taken one modern sulfonylurea which has got it is weight neutral. Actually glycoside has got some, it is something like the rose without thorns actually. So though there are no direct comparative studies like the glimepiride has got with the linagliptin, that is called Carolina, it's a direct comparative. For the first time in the field of medicine, they have used this particular in the cardiovascular outcome trial Carolina, the linagliptin, the Boehringer Ingelheim people, they have tried with the active comparator was glimepiride, and I was one of the principal investigators, and the study went on for 6 years actually. So that also showed the cardiovascular safety is at par with the inference is what we had given. The inference is the linagliptin is non-inferior to glimepiride as far as cardiovascular safety is concerned, but the concerns with the glimepiride arm was there was little bit increased in the incidence of hypoglycemia, and the significant weight gain of 5 kilos after 6 years was the coincidental finding with the sulfonylurea. So that is this thing. But the glycoside is rose without thorns. It is weight neutral definitely, and the incidence whenever you use the XR preparations, the modified release MR preparations or the ER preparations, extended release preparations, the incidence of hypoglycemia when you use 30 milligram especially, that goes down very significantly when compared to this the glimepiride also. So absolutely, your regime is accepted. Wonderful regime.
So Krishna, how about this glyphosate XR60?
Yeah, you can go to 60 also. As far as XR is concerned, you can start with 30. You can increase it to 60, and the maintenance is 60, and don't go for 120 again.
Okay, so that means you're saying start with 30.
Start with 30. You wait for a couple of months. You monitor the blood glucose or ask the patient to go for SMBG. That's what I said. 7-point formula of monitoring of self-monitoring blood glucose. The blood sugars are okay. That's good, well and good. You don't need to escalate to 60 milligram. If something is wrong, you can escalate to 60 milligram. Rasdeep.
So that means the diamacron 30 is not a sustained release. Again, it's a once a day dose.
Yeah, it's a once a day dose.
30 milligrams.
Diamacron itself is a sustained release.
Okay. So any other formulation, that way other formulation we can use it as a 30 milligram.
Yeah, 30 milligram you have from DRL you got Reclide XR30, and from Alchem you got the Euclid XR30, Euclid XR60. The same ready people have got the Reclide XR30 and Reclide XR60 also. There are so many economical preparations when compared to the diamacron.
Okay. One last
And yeah, before concluding my answer, see there is one more other option, Rasdeep, to start with. Instead of taking a glimepiride, you can start with a sensitizer metformin. Maximum dose you can start with, that is 1000 in the morning, 1000 in the night. One linagliptin always 5 milligram in the morning enough. And you can start the SGLT2 inhibitor. If the patient has got affordability, you can go for empagliflozin 25 milligram once a day. Or if the patient has got some problems with the money, you can go for the one of the greatest all-time molecules, the dapagliflozin 10 milligram. That is also wonderful, because keeping the recommendations say that that is a mandatory molecule that is to be started early in the course to have the benefits. What you so-called call the cardio-renal metabolic hepatic continuum is, you want to break at some point. The use of SGLT2 inhibitor is definitely required. Instead of that, you can go for, say, now the triple drug combinations have come into vogue. All three drugs in one tablet. So that can be used. You find 100 milligram of sitagliptin, you find 1000 milligram of metformin, you find 10 milligram of dapagliflozin. So why I am telling this is, that has got the greatest advantage of not letting down the patient with hypoglycemia first. Per se, nothing is acting on the pancreas. Whereas in your case, glycoside directly acts on the pancreas. It tries to squeeze out the insulin. So whatsoever is remaining in that, it tries to take out the insulin. Whereas in this triple drug, nothing is going to act on the pancreas. This is all extra pancreatic actions. So pancreas is untouched. So no incidence of hypos and no weight gain. Further, the advantage of the SGLT2 inhibitors is it reduces the weight by 3 to 5 kilos in a period of 3 to 6 months. If the patient strictly adheres himself or herself to this particular the diet and exercise. Yeah, yeah, that's what. See, yeah, the main point you have raised is metformin is the first pleiotropic drug, first of all, After that is the insulin. After that is the statin. And the fourth pleiotropic drug is SGLT2 inhibitor. Exactly raise the point, Rasdeep. You just have hit the bullseye. That's it. So pleiotropism is very much required. So we according to HPS, the heart protection study, any type 2 diabetes, we are bound to put the patient on statin, whatever it may be, either atorvastatin or the rosuvastatin, whatever it may be. So anyway, we need to address the comorbidities, like not only the diabetes. They all the time remember ABC, Rasdeep. You know that, okay? The A1C stands for the blood sugar, and the blood pressure B, and the C is cholesterol. If we don't address ABC, you are not going to achieve anything. So try to keep all the three around 100. That is the fasting is around 100, and the post lunch is around 100, and the LDLs is around 100, and the patient is going to live for the bonus is 100 years. So statin is very important, as well as the antihypertensive therapy is very important, as well as the primary concern is the management of diabetes, very, very important.
Yes, we have to take care of the CRM diseases.
Yeah, absolutely. That's what.
One last question.
Yeah, please carry on.
Now, like we have a Trazenta Dew, which has a linagliptin is a 5 milligram OD. Is a one size fits all, right? What
Okay.
is the company, the Trazenta Dew is making a 2.5 plus 1000 milligram.
Yeah.
So it's a
You
so
can
the linagliptin
you
in this combination.
yeah. So you can use this particular molecule, the Trazenta Dio. That is from Boehringer Ingelheim, the original innovators, the mother of all these molecules. So you can have this benefit of 2.5 milligram of linagliptin BD, 1000 milligram of metformin BD in one single pill, and you can add one dapagliflozin to that, enough, so that the patient is getting the maximal therapeutic dose of metformin, the maximal therapeutic dose of DPP4 inhibitor, the linagliptin, and you can also add this particular the maximal therapeutic dose of SGLT2 inhibitor, 10 milligram, enough.
So see, I always prefer SPC, single pill combination.
Yeah.
But in this case,
Yeah.
in order to have a linagliptin as a one dose, a 5 milligram stat dose, so shall we use two different molecules? Metformin separates linagliptin separate as a different molecule.
Yeah, the thing is, whenever you got fixed dose combinations, FDCs, all in one single pill, the compliance and the tolerance of the patient goes up. They'll not miss out any tablet. One tablet in the morning, finished. That too, if we break that, the metformin 1000 in the morning, 1000 in the night, again a linagliptin, and again an SGLT2 inhibitor, patient might miss out one or two tablets.
Yes, I know that.
And when the patients come to us, they are very intelligent. They say, we have used everything. So that is the reason I ask the patient to get the empty strips first of all, especially in case of resistant hypertension. It is always in our country, resistant hypertension is always pseudo resistant hypertension. When I ask the patient to get the strips after a month, using triple drug, one being as per the definition, one being the diuretic, they never get the strips. That itself shows that the patient has never consumed the tablets, and he always says the BP is at higher side. See, 80% of the times it is pseudo resistant hypertension. And even in that case also, addition of this DPP4 inhibitor, the SGLT2 inhibitor, either the empagliflozin or the dapagliflozin is going to have a wonderful role, because these molecules, apart from the glucose lowering effect, they reduce the weight, they reduce the blood pressure, the 24-hour blood pressure, nocturnal blood pressure. So it controls the nocturnal hypertension as well as the resistant hypertension, and the cardiovascular protection in the form of 3-point MACE, and the reductions in the heart failure and the reductions in the hospitalization for heart failures, the reductions in the chronic kidney disease or the diabetic kidney disease, they thereby improving the EGFR, and even the chronic liver disease, especially prior to that, the stage of cirrhosis, that is the either the NAFLD or the NASH. Now the terminology is changed actually by the International Society of the Hepatology. So now they say it is MAFLD, metabolically associated defective fatty liver disease, and the MASH, metabolically associated steatohepatitis. So that plays a wonderful role, and apart from that, even the hyperuricemia is addressed by this different mechanism, that is called pleiotropism, what you exactly raised. So that is going to reduce the serum uric acid levels also. Whether it is a clinical case of gout or whether it is simple hyperuricemia, any reductions in the uric acid levels has got a favorable effects for the patient especially. See, these three things all the time they coexist. First is diabetes, second is hypothyroidism, third is hyperuricism. So either the gout or the hypothyroidism. See, once we diagnose type 2 diabetes, I always rule out the gout. I always rule out this hypothyroidism, because they coexist. The deadly triad, the diabetes and hypertension and the dyslipidemia, like this. The second deadly is the type 2 diabetes and the hypothyroidism and the hyperuricemia. Whether it amounts to gout clinically or not, anything around the above 7 milligrams of deciliter of uric acid, we call it definitely hyperuricemia, and that also is taken care by this particular the SGLT2 inhibitor, Rasdeep. That is the reason why we call this particular the SGLT2 inhibitors a pleiotropic drug again.
Thank you, Krishna.
And only minus point with this particular this thing is there are certain contraindications. See Newton's third law holds good everywhere. Wherever you go, Newton's third law, there is equal and opposite reaction. For every action there is equal and opposite reaction. So it has got some side effects, like it increases the LDLC, which is not a desirable effect. But when compared to the benefits of this particular molecule, so this is not a big deal actually. See the 5% elevation in the LDLC with the SGLT2 inhibitors is not a big deal when compared to the so many vast benefits it has got on the patients.
Same is with the statin therapy.
Yeah, statin. See, statin induced diabetes. So we need to whether it is cost effective, or we need to see the pros and cons. We need to strike a balance between the pros and cons. We need to come to a decision whether this is doing the perfect job or not. So statins rarely cause. See, that also is not taken for granted actually. There is an entity called statin-induced diabetes. We really don't know whether the patient has developed diabetes naturally or over a period of course. Who knows? Not everybody is on statin, right? Whenever we see the patients of the type 2 diabetes coming to our clinics for the first time, we don't find anybody using statin. But still, the patients are vulnerable to the type 2 diabetes because it is multifactorial in origin. The occurrence of type 2 diabetes itself is multifactorial in origin, like the atherosclerotic cardiovascular disease. All the macrovascular complications of diabetes, they are not totally glucose dependent. Whereas the microvascular complications, per se, the retinopathy, the diabetic kidney disease, and the neuropathy, either the sensory neuropathy or the autonomic neuropathy or the motor neuropathy, they are more the glycemic dependent. As the 1% of HbA1c goes down, there is a significant reduction in the incidence of microvascular complications, but not so with the macrovascular complications, because the heart attacks have got multiple the etiological factors. The strokes have multiple like the patient has got diabetes, hypertension, dyslipidemia, lipoprotein A, smoking and alcohol, and sedentary lifestyle, and obesity, family history of diabetes. So many things the patient has got before he gets a heart attack. So this is not totally glycemic dependent. The all the three macrovascular complications, either the CAD or the PAD or the strokes, they are not totally dependent on glycemic control, but definitely 14% of the macrovascular complications are glycemic dependent. There are so many other factors like smoking, alcoholism, sedentary lifestyle, obesity, and all, diabetes, hypertension, dyslipidemia, especially the not only the LDLC, the lipoprotein little a, that is the big culprit nowadays. So many factors are there, and there are some modifiable risk factors, and there are certain unmodifiable risk factors. Unmodifiable risk factors will be age, and the sex, and the ethnicity, and the family history are the unmodifiable risk factors. Anyway, we cannot modify the unmodifiable risk factors. What I tell the patients is, at least we try to modify the modifiable risk factors. Like at least control diabetes, control hypertension, control dyslipidemia, reduce your weight, try to maintain an ideal body mass index. So this is the message I give, Rajdeep.
Yeah. Thank you, Krishna. Thanks a lot for such an elaborate.
Yeah, thank you so much. Thank you so much.
Thank you.
So, any questions? You can please raise your voice. You can like my dear friend Rajdeep Srivastava has asked. You can raise your this thing, and you can ask me straight. Okay. It's a wonderful interaction. I'm glad to take questions, not only on insulins, not only on today's topic. Any topic you want, you can ask me questions. Any part of diabetes, any part of hypertension, any part of the dyslipidemia, whatsoever you face the dilemmas in your clinical scenario, in your day-to-day practice, you can feel free to ask me, so that I'm glad to clarify the doubts. Are there any things in the chat box? Okay. Prashant?
Sir, yes, sir.
Prashant, are you there?
Yes, sir, yes, sir.
Yeah, any more questions in the chat box?
No, sir.
If there are no questions, so we'll wait for 1 minute or 2 minutes, and we'll wind up this session, okay?
Sure, sir. Yes, sir, okay.
You just tell me after 1 minute exactly. If there are no questions, we'll wind up this
Sure.
session.
Sure, sir.
So much delighted, Prashant, my friend who is very busy. He moves all around the
Yes,
globe.
sir.
He holds a very high post in the UN actually. So he's a medical director actually. So very fortunately, he logged into my session. See, he'll never miss out my session.
Okay. I think there is no more questions.
Yeah, so we can.